All right, so we got a couple cases to go through today. I was debating which one to start with first, but I'm going to start with the more unusual one, and then we'll go back depending on how much time we have, and we'll look at kind of a more straightforward type of case that you'll see, especially phase 1 type case. So, sometimes as practitioners, life is not fair, and certainly as patients, life is not fair. And if any of you think you'll go your whole career without making mistakes, you're probably wrong, okay? So I want to show you a case that this is how this case presented to me. I'm sorry, this is not how this case presented to me. But I want you to look at the images here, and I don't have complete images. So I want you to make as many diagnoses as you can based on this one image that I do have. And if you have questions, then I'll answer them as best as I can, and or I'll make educated guesses. So looking at this panel alone, what are some things that stand out to you that you are concerned about? Or what are some of the diagnoses that you're seeing? Let's start generating a problem list. Say that one more time.
Overlap canine and lateral.
Okay, so overlap canine and lateral is an observation. So what problems are associated with overlap canine and lateral? Crowding is also sort of an observation, right? That's a descriptive word that says what you're seeing. But what do both of those things mean? What are we worried about when we see overlap canines and laterals and or crowding? Insufficient arch length is also a description. It would describe a situation in which there's not enough room for the teeth to come in. But what does that mean? What do we worry about when... Okay, I heard two things, impaction and resorption. What's that? Yes, so impaction, right? So what teeth in particular would we be most worried about becoming impacted in this case? Okay, which canines? Okay, maxillary canines, all right? Why do you say that? So the lowers are rotated. I would agree they appear rotated on this image. Obviously it's 2D, so we can't see them completely, but they appear rotated. Is that a good thing or a bad thing when it comes to potential risk for impaction? Not a great thing? Who agrees that rotated canines are not a great thing as it relates to impaction? Okay, so you're saying it is a great thing if you're trying to avoid... All right, we have a debate. I love it. All right, so who feels that rotated canines are not good when it comes to an erupting canine? We're all getting shy. Couple, few, 4, 5. Who feels like rotated canines are potentially or are better for bringing them in? Okay, so we're split about 50-50. Maybe a little bit more on the better side. I mean, so I actually don't know the answer if there's a research behind it or if they've ever looked at it. I mean, anecdotally, it kind of makes sense that if it's rotated, there is less space required for that to come in. And typically with impaction cases, that's what you need, right? If you have space, the teeth do what they're supposed to do. So my guess would be that it probably would be less likely to become impacted if it's rotated because it can find more options or more paths to be able to come in. But let's go back to the maxillary canines. So we talked about impaction. So if these canines were to impact, which direction do you think that they would impact, facially or palatally? Got a 50-50 shot. Facially, all right. So somebody make an argument for facially. So why when you look at this, what is it that's telling you that they might impact facially? Okay, so they look smaller compared to each other, compared to the neighboring teeth. Okay, I would agree. I think that's a good argument for possibly facially impacted teeth because when you look at all the other teeth, especially the premolars, right? The premolars definitely look more magnified compared to the canines, okay? And if that's the case, we again, could just be that they're big premolars. We don't know. It's a 2D image. But that's at least a good argument, right? The canines are not as magnified as the premolars, so perhaps the canines are more facial than the premolars, okay? Anybody else think facial or anybody else think palatal, and why?
According to boards articles, crowding usually results in facial impact.
So according to the boards, canines impact facially more than they impact palatally? Interesting. It's been a while since I've taken boards. That's definitely not my experience. That's really cool. Yeah, I mean, in my experience, there's a lot more palatally impacted. I see a lot more palatally impacted canines than I do facially impacted canines. But that's interesting. We do a lot of early expansion and whatnot, so we have less crowding situations perhaps, but that's interesting. So, okay, so you have the argument of just odds, right? So according to crowding, so okay, I'll take that argument, that, you know, due to the odds, it's probably facial. Okay, is anybody going to say anything about palatal or make any type of an argument on why they could be palatal? Okay, so when you say kind of like this, what I think you're describing is that they are more inclined or mesially inclined toward the midline, right? And in general, when you see a canine that's more mesially inclined, they tend to be more palatal than more facial, okay? So what if I told you they weren't really facial or palatal? Okay, what evidence can you start to point to that would indicate that maybe they're not palatal or facial, that you can see potentially on this panel? Okay, so which lateral? Okay, so it looks like there is resorption happening possibly on this lateral. Now, it's a 2D image, it's hard to see. We can see that the root formation is not complete, so is it resorbing? Is it incomplete root formation? But certainly if there is resorption there, that would tell you, oh, well, maybe it's right in the middle, okay? We talked about the mandible. We talked about the potential of impactions there, okay? Now, what about, are you more, let's see, why are you less worried about the mandibular impactions? What are you seeing that, we mentioned they're rotated, all right? So maybe they can squeeze in somewhere. But why are you less worried about the mandibular canines impacting than the maxillary canines impacting? Okay, so you have leeway space. Are you worried about one side more than the other? Yeah, the left side. Why? Right, you have an entire primary canine that's missing. Okay, so there is some leeway space specifically on the right side more than the left. Okay, so why else are you less worried about the mandibular canines? Say that again? Okay, well, I would agree on the right side. There's, you know, like I'm not so worried there, and you can utilize that space. On the left side, obviously, with the, you know, they lost that primary canine early. Why did they lose that, most likely? What's that? Could have been, most likely, though. Yeah, probably, right? I mean, this is a crowded case, right? So, you know, primary or permanent teeth are erupting, and if there's not enough room, they tend to take out more teeth, and you can see that that's exactly where that lateral is. So most likely, that was an indication earlier of the crowding, okay? Now, again, look at the position of the canines. What's good about the lower canines, mandibular canines? What's good about those that tells you, hey, this may not be as high of a risk of impaction? Okay, they're straight up and down. What's that? Exactly, yeah. So there you go. So one of the things is they're past the apices of the roots, right? So we know when it's not that it couldn't impact at this point, but it's much less likely to impact if the tips of the canines are past those lateral mandibular incisor roots, which they are. And also, as it relates to the tip of the canine, you mentioned it was in the middle. That's correct as well, right? So it's not going over. It's not already crossing over. The direction seems to be in the right place. So overall, less worried about that. Now, obviously, you don't have any other information facially. We don't have a Ceph. We don't have anything else. But in your mind, what would you be thinking treatment-wise if you saw this pano and you said, hey, you know, like I'm going to throw a dart at the board and I'm just going to go with the most likely thing I should probably do based on the information I have. Like, what would you do in a case like this? Okay, possibly expansion, right? So if we expand, we're going to create more room in the top jaw. Okay, so hopefully there's going to be more room for these canines to come in. What else is... Okay, what other benefits do you get from expansion? We talked about having more room for the maxillary canines, okay? So what else do you possibly get with expansion? Okay, so if you expand the top jaw, then you can then upright those lower mandibular teeth, and now you have more space for the lower teeth, even though they're not the primary concern, right? But we do have quite a bit of a lack of space here already, so having more space on the bottom is going to probably be beneficial, okay? Now, let's take a step back, and what else is unusual about this case when you look at the pano? Like, what kind of like stands out as like a little bit odd? Yeah. Okay, so the mandibular midline is shifted to the patient's left. What could that indicate? What? Yes and yes. Probably most likely, like Austin mentioned, it's probably due to the loss of the canine. Those teeth shift over, right? But you mentioned, yes, and if let's say it was asymmetric growth, all right, what would you expect to see on the models when you articulated them together? A shift, right? So they may have a crossbite on one side, right, if it was caused by the asymmetric growth, or if it caused the asymmetric growth, either one. Okay, so let's put that aside. What else do you see? What's a little unusual? So the roots are short, kind of weird. What else did you say, the second thing? Yeah, so what would be another way to describe open? Yeah, like unerupted, right? That's kind of weird, right? I mean, they have all 4 mandibular incisors. So which teeth should be erupted on the top? At least the centrals, right? The 6-year molars are in. At least the central should be. So why aren't they in? What's that? Maybe. You know, I don't know. Like I don't know that I've ever seen a digit habit where the tooth doesn't erupt. Typically, it just erupts and stays higher. You know what I mean? It's still breaking through the bone and gums. It's just that it's up higher. And that could be the case here, but although you do see some kind of bone in between those centrals. So these are kind of like unerupted. I don't know the answer to why these were interrupted. Again, I didn't see this patient at this stage. But again, when you look at this pano, there's a lot of red flags. I mean, at a minimum, you're going to either treat this patient or probably refer them to ortho for evaluation, right? Okay, so neither of those things happened until much later, okay? So this is when I saw the patient for the first time, all right? How did we do with the mandibular canines? I mean, they came in, right? Rotated, but they squeezed their way in. What's that? Tops no bueno? All right, so we have we go back to our debate. Who thinks that the canines are palatal? All right, one shy hand. Who thinks that they're facial? Oh, we got a few, quite a few facial. Why facial? I'm just curious. Okay, do you see any bulges on the facial? Where is it easier to see? What's that? Where is it easier to see bulges, typically? I agree. Yeah, right? I mean, the facial, there's not a lot of tissue there, right? So you would probably see, you know, if the canines were there. Now, could they be hiding on the palate? Maybe, but looking at the timeline, I haven't told you how long it is between the first image and the second image, although you know it's long enough for all of our incisors to come in and all of our bottom permanent teeth to come in, so you know it's been a little while, and you saw where the canines were before, so you would think that if they were palatally impacted, you would see some type of bulge, at least on one side, but you're not seeing that, okay? So what else let's diagnose this case more completely now that we have a more complete picture. So what else are you noticing that you may want to address to add to your problem list in this case? Again, we'll show the current images or the images at that time in a minute, but just looking at the facially and looking at the intraoral images, what else are you seeing that's going to need to be addressed? How about the smile? When you look at the smile, what's right, what's not right? Say that again. Okay, so the lower midline is still shifted off to the left. Now, at this point, do we think that that was due to the loss of the canine or due to a functional shift in crossbite? Probably the canine, right? Because there is no crossbite, and we know they haven't been treated up to this point, right? So you lose space, midline shifts over. Not a huge deal. When we work out the crowding, we'll be able to push that back over. So not a huge concern there. What else? Okay, yeah, so a cant with what side being inferior? Well, left on the screen or her right side, right? So her right side's a little bit more inferior than her left side. What about her, let me ask this question. So do you think that her occlusal plane, right, her occlusal plane angle, do you think that it's more steep or more flat And why? Again, I haven't showed you a Ceph yet. Flat. And why do you say that? Yeah, so it's a little bit more gummy in the back than the front, which would indicate like a little bit more flat of an occlusal plane angle, right? What's our ideal? So who is studying for boards? What's the ideal occlusal plane angle typically? Yeah, 6-7 degrees, somewhere in there. All right, let's look at the teeth here. Okay, all right. So not a ton of wear. I mean, that's nice. Maybe a little bit on the insides of the ledges there, but not too much going on from that standpoint. We found our canines. So now what do we do? What's that? Canine subessentials. So let's work through that. Canine subessentials. What is that? What benefits us there? What's that? Okay, so she'll have teeth in the front because, I mean, prognosis of 8 and 9? Yeah, not good. Not good at all, right? So, any other ideas? So we had canine subessentials. Any other ideas? Haven't done anything yet. That's it. That's all we got. What's that? Do laterals what? Like push the laterals. Wait, say that again. What are you doing with the laterals? Oh, like leave the centrals and try to pull the canines back into the lateral spots? Okay. Okay, restore the canines to look like laterals? Okay, so like a canine substitution for the laterals, and then if you lose the centrals, you know, either a flipper for now or implants. Okay, it's another option. All right, any other options? Do nothing. Send them back. What's that? Yeah, no treatment's always an option. Okay, so who likes the canine sub for the centrals the best? Out of your options. I mean, like, you know, assuming that, okay, so everybody likes no treatment, but let's put that one outside, okay? So from the other two treatment options we have left, who likes canine sub for centrals? A little more than half of you. Who likes canine sub for laterals? A few of you. Any other ideas before we make our decision here? All right, I guess we're going with canine sub for centrals. All right, so let's talk through this. All right, so how does this work? How are we going to treatment plan this? Like, what do we have to do to make this work? Okay, so we got to get the lateral roots out of the way. We can do that how? With braces, right? Yeah, you can throw some braces on there. You can tip those roots distally. Okay. Any risks in doing that? Yeah. Right. So it's kind of like you're in between a rock and a hard place. Right? You don't do anything, canines are probably going to keep resorbing those roots, at least on the right side. The left side, maybe not as much. I mean, it's kind of more out of the way. It's definitely targeted in on the central. And if you move them, you know, you're moving that root quickly, you can have some root resorption from that. So you get the lateral roots out of the way. Now, what else do we have to do? Okay, so expose the canines. Okay, so now they're exposed, and we've gotten the lateral roots out of the way. Now what do we do? Okay, so you extract the centrals. So she's in middle school at this point, right? What's that? Yeah, is that our plan? So we're just going to extract them and be like, all right, you'll have teeth eventually. All right, well, what can we do for teeth? Okay, so we have Pontics on the wire. We've got the canines exposed and bonded. I'm assuming with a chain or something, okay. So we got the canines exposed, bonded, chain. We have Pontics on the wires. The canines are in the middle. All right, so now what are we doing? What's that? So what kind of anchorage do we need? Yeah, so we need, what direction does the anchor, what force is the anchorage going to be fighting against? we're going to be pulling those canines in, right? We're going to be pulling them down, all right? So the anchorage force is going to be pushing things up, okay? We already had a flat occlusal plane, right? So unless we design something specifically to address that anchorage need, what's going to happen if we pull those canines down as it relates to our smile line and smile arc? It's going to get worse, right? It's going to become flatter. You're going to show less in the front, maybe more in the back, okay? So what can we do? How can we increase our anchorage in the front so that as we pull those down, okay, you could wear elastics or TADs. Let's go with elastics first. So if you wore elastics, where would you wear them? Okay. Okay, so yeah, just kind of like some sort of a triangle over here on either side. Kind of keep a little bit more anterior. Try to bring those in that way. All right, so if we use TADs, what might we do with TADs? Okay, you could lower TADs. If you put some TADs on the lower, I guess you could run an elastic directly to the TAD up there. That would be one way of doing that without extruding the lower teeth. But I don't know how much of a difference in anchorage it would be. It might help with your deep bite correction, right? Because you're not taxing those anterior teeth in the front. Where else could you put a TAD? Okay. Okay, so you could put something in the maxilla and you could run some type of anchorage to either one of the teeth or just have a free-floating bar in the area that you want to extrude those teeth. For sure, either one of those would work. All right? Now, let's eliminate elastics and TADs. Okay? What other option do we have that may result in getting us more incisal display when this is all said and done? Maxillary expansion, right? Now, does that necessarily help the posterior-anterior discrepancy problem? No. As you expand, the whole maxilla comes down. But if the entire maxilla comes down, that does help our gingival display in the anterior, right? So not so much our occlusal plane problem, but possibly the aesthetics just because they'd be showing more teeth, okay? So what do we want to go with? We've got some options. What's that? Go expansion? All right. Anything else? We can use anything now. We can use all three if we want. So we're going to do expansion. All right. What else are we going to do? Okay. So just go with the expansion and then just reevaluate. Okay. So we talked about how are we getting these? Are we leaving her without centrals, or are we doing central pontics? And then how are we applying traction to those teeth? Okay, so design some mechanics to bring the canines more palatally, and that would allow you to keep like pontics in more facially. All right, let's just rule out some other things real quick. Okay, so TMJ, no issues, no concerns. All right, so no problems there. Here's our Ceph. Was our occlusal plane a little flat? I don't have it all traced out, but yeah, it's a little flat, right? You can kind of tell. Okay. Lip at rest, fairly normal. Any other concerns from the Ceph or anything else that stands out to you? The second molars. Okay. Yeah, what could happen with those? Yeah, they could get stuck, right? Now, what's good about the situation with the second molars on the bottom? Okay, they're unerupted, right? So we have, and they're really probably not supposed to be erupted yet, right? Because the upper second molars are still not in as well, and they have plenty of space, right? So we have eruption in our favor. We have active roots. So hopefully those would come in. You also, and this is something that we see sometimes, right? When pedo does crowns on first molars, what kind of crowns are they typically? Yeah, they're stainless steel crowns, which have little borders and edges, which sometimes get in the way when teeth are trying to come in, right? So they don't have stainless steel crowns on those teeth, so that's a plus. And we also talked about the ability to expand. Now, if we expand, we're going to be uprighting the lower, so we're going to have some kind of movement going on back there, making more room, increasing the arch length. So there's a few things to our benefit as far as having those second molars come in. Anything else jump out at you on the Ceph? Okay, so where are you seeing class 3-ish? Okay, skeletally? Okay. So yeah, I would agree. Yeah, so if you do like an A, N, B, probably a little bit less than 3, let's say. All right, so maybe a little bit of a skeletal class 3 tendency, but what are we looking at dentally? More of a class 2 dental. Why? Yeah, she lost the space, right? There's basically 2 teeth that didn't come in. So yes, everything's going to drift forward. So the class 2 dental makes sense. All right, what about our airway? Nothing huge there, right? Get a pretty good look at those impacted canines and the amount of root we have left on the centrals. And we have finally confirmed our position of our canines being in the middle of the arch here, okay? So going to be much easier to treatment plan this case if we can see it in 3D. And so this is what that looks like. This is called anatomage. Basically, they section out the teeth so that you can do treatment planning and or case presenting. You can show what you want to do. So in this case, we talked to them about having the centrals extracted, having the remaining baby teeth extracted, erupting those canines more palatally, like we discussed, putting her centrals back in place as pontics, bringing the canines in palatally first, then bringing them forward and having them restored. Now, in hindsight, I think that the expansion would have been a great idea. I think that would have helped us. I think utilizing TADs to help improve the occlusal plane angle, whether that's posterior intrusion or anterior extrusion, would have been great as well. We did not do either of those things. So we put together a plan. We worked with a good restorative dentist, and we worked out who was going to do what when. And then afterwards, everything's going to get bonded to look like the teeth that they are. So here was the extraction of those teeth, or of the central teeth. So he went ahead and cleaned them out, basically endoed the top portion of the tooth and then sealed them off so that we could use them as pontics. And got those canines exposed. The orthodontic part of the treatment was not nearly as exciting.
Not near as exciting as exposing canines. Here's our activating mechanics. Not active, active, not active.
All right, so we're utilizing some posterior anchorage. And that's what that looked like. Okay? So we're basically pull, pull, pull. And we have her centrals back in as her pontics. This is what that looked like. We move along. All right, so she comes in, we retie, comes in, we retie. And we start bringing them down. You can see that that left side is moving quicker than the right side. We did add distal root tip to those laterals. You can see that the right lateral is experiencing more root resorption than the left. We can see that the tissue really, really likes everything that we're doing. All right? So, had a little bit of a tissue issue. All right? You'll have those. So we had to clean that up a little bit. And at this point, rather than continuing to pull from our loop, we went ahead and bonded brackets on those teeth, and we ran an auxiliary wire. So mostly this auxiliary wire is going to be pulling these teeth down, right? Because it can't move them so far facially because they're going to run into the centrals that we have there. But again, this kid's in middle school. Like, I don't want to send this kid to school with crazy, funky looking teeth. So we tried to get as creative as possible. And as we needed that wire to continue to work, we just sort of pushed those centrals out of the way to the point where hopefully we could get something bonded on those canines and make them look like some semblance of a central incisor before we take those out. And this is where we were at that point. And so we went ahead. You can see here we're definitely not facially where we need to be. But it was close enough that we could get something on there. Now, I do my own temp bondings in the office because it's really, really hard to communicate what needs to be done on a temp bonding, and dentists tend to just make everything look straight and fill spaces, right? Which is not what we want orthodontically. We want the right size, width, and angulation of the tooth so we can continue to straighten it. Obviously, these teeth aren't straight, so they were running into each other, so we had to bond it in a way that this angulation was maintained so I can remember where the root is without having to take an x-ray every visit. But our height and width is good. So that's how we bonded those. And you can see that there was still a rotation as well. We want to build all of that into the restoration so that when you straighten those teeth, the roots are straight as well and hopefully not derotated. And she goes back to school and she's still got front teeth, or at least something that looks sort of like normal front teeth. Okay? Teeth move out. So we also bracketed the premolars, as you'll see, more incisally so that those could be intruded, so our gingival margin levels could be closer to ideal relative to everything else, with the plan to have the dentist restore those to create normal sized canines at that point. So these are the temporary bondings. This is when we debonded. And you can see the temporary bondings on the central still, which are the canines. All right. She kept the roots, which were great. The 12-year molars on the lower did come in. The wisdom teeth were removed on the bottom. I'm trying to remember. I don't know why we didn't. Oh, yeah, that's right, because the top ones we're going to use because she's shorter tooth. So she had the lower wisdom teeth removed. Now, did we upright the roots perfectly on the second molars? No. Again, hindsight's 20/20. Go back, put a bracket on that tooth, get that root back a little bit. We ran mechanics with our wires, RCOS type wires, to try and address our occlusal plane issue. Not perfect, still pretty flat. Lip at rest, okay. Not a ton of changes in the airway. Not a ton of changes in our jaw joints. And then she went to the restorative dentist, and the restorative dentist was able to rebond the centrals so that it's matching, and to bond the canines as well. Now, again, hindsight being 20/20, our mechanics anchored to the posterior teeth for the anterior extrusion did help our occlusal plane, but in the end we ended up a little bit vertical maxillary insufficient. So had we expanded, maybe that would have been enough to bring everything down, and we could have had an even more ideal result. But she's happy. And, you know, out of all the possible things that could have happened, I mean, I was happy with where we got from where we started. But again, we learn and we move forward. We make mistakes. And we try to get better. So,
how stable were the laterals?
I don't know. I've never seen her again. Yeah, so she hasn't come back in for any retainers or anything like that. Certainly if she does, you bet I'm going to be updating the x-rays. You know, I would love to. I mean, it's probably been, it's been a minute. It's probably been 5 years since we debonded her-ish. So, yeah, maybe I'll have to have the office give her a call and get her back in. Because, yeah, I would love to see that as well. I'd love to know. Yeah.
What are your thoughts on doing like a permanent fixed retainer on that one? Because those laterals are so already pointed as well.
Yeah, so what research are you aware of as permanent fixed retainer? So, okay, here's what I'm aware of, right? So we use stabilization splints when there's acute perio problems, right? So you have a mobile tooth following trauma, sometimes just perio stabilization for advanced periodontal disease in adults. And the idea is that no individual tooth is going to be taking more force than the others, if that makes sense. And so, like in a case like this, I mean, number one is like make sure that the occlusion is balanced, and ideally, the laterals aren't going to have a lot of force on them. And obviously we're talking to her about things like, hey, don't be using your front teeth. Other people might be biting into hard things, and you don't want to do that, right? You don't want to stress them. If the occlusion is correct, when they're chewing, they shouldn't be hitting on the anterior teeth. It's more guidance. If the canine guidance is correct, even though it's her premolars, that should be good. So the only reason I would consider doing that is if there was still mobility of those laterals, just because of the shortness of the roots. But I'm not aware of long-term data because the other side of that coin is the hygiene problem, right? So if you have not perfect hygiene, well, now you have possibly the potential for perio issues on a tooth that's already compromised. So to answer your question, we didn't do fixed retainers. I think it's a good thought. I don't know I don't know the long-term research on, how much it helps or not, right? Unfortunately, fortunately, there's not thousands of cases walking around like this, right? So we don't have sufficient data to really know. But there are a lot of short root cases, but I don't know. It's definitely worth thinking about. I'm not a fan of fixed retainers because they always break. I mean, at some point they break. So it's something that the patient's married to. They're harder to keep clean. So for me, it would be more something like if we start to have a progressive problem with them, then we would look at other options. But if they're stable and they're not super mobile and they're not progressing, we're not seeing continued problems, then I would just leave them in regular Essex question.
So I noticed that when you finished the case, you had the first premolar and stuff, or 1 or 2 meters under the tooth. Is that something you do for stuff, or just the general?
So when we intruded the premolars, yes, typically we'll always leave the gingival margins on and have those teeth be restored. So you can bring them all the way down, and functionally you can be okay. Sometimes the palatal cusp, depending on the anatomy of the tooth, will get in the way and cause interferences or problems. But from an aesthetic standpoint, you're always going to be lacking just because the tooth is shorter, right? The CEJ to the cusp tip is much shorter on a premolar, first premolar, than it is on a canine. And so aesthetically, you're always going to have these gingival margins which are off. Now in her case, she doesn't show that a lot anyway, but you can see even like with the body of the teeth, it's a difference. It's going to look aesthetically not as good. So we'll always start with, my number one goal is always to start with the most ideal thing possible and then work backwards from there, right? So we have that conversation like, hey, you don't have to have these teeth restored, but if we don't restore them, you're going to notice that they're going to look a little short compared to the ones in front of them. And there'll be like a little dip down where, when you smile, those teeth will be a little bit more prevalent. And who knows, like, it's hard to say, but if we would have brought those down, you might even see like some of the gingival margin there on the smile with those being lower on that side. So we always start from ideal and then work backwards. But yeah, it is 2 more restorations that she's going to have to maintain, but aesthetically, we felt that the trade-off was worth it. Any other questions on this case? And then we'll go through the other one a little quicker. All right. So yep. Yep. So yeah, back when we bonded the teeth, basically, that was when the majority. Let's see. We can go back and see. I don't know how good of a job I did, but yes, we tried to upright them. So yeah. So basically, yeah, when we bonded those teeth, we bonded them at the angulation with where the roots were, right? So when we put brackets on them, they uprighted. Yeah. So decent job with the root uprighting. All right, let's check out this case. All right, maxillary deficiency. We have that in common with both of these cases, although this is a little bit more severe from a maxillary standpoint. But let's start looking, and again, let's diagnose based off the imaging that we have, okay? So this is all we have for now. So what are you seeing? What's standing out to you? Okay, prominent chin. Okay, so maybe class 3 type tendency. Pretty decent observation. All right, what else? Okay, so it's off to what side? It's a little bit off to the left. So what might be cooking underneath all this? Okay, could potentially be a crossbite with a, hopefully, right? Hopefully. Because if we don't have a functional shift, then what do we know happened? Yeah, skeletal asymmetric growth, right? That's a much harder problem. Well, yeah, much bigger problem than a functional shift. Okay, what else do we see? Dark circles, yeah. Allergic shiners, right? So what kind of questions are we going to want to be asking? What's that? Yeah, we want to ask the sleep questionnaire, right? Are you snoring? You know, what do your activities look like throughout the day? Mouth breathing, constantly sick, allergies, all the things. Michigan Sleep Questionnaire is the one we use, all right? What about like the facial form overall? Like what, kind of more like an ovoid facial form? Like do you get any sense of, do you get any sense of her maxilla being smaller, bigger, hard to say? Like what are you seeing? Let's keep looking. All right. What's that? So we see the midline's off to the left. So you guys picked that up before you even saw the teeth, which is good. Okay. So definitely buccal corridors. Oop, where's this mouse thing? Here we go. There we go. Pretty narrow, right? You can see a lot of the gums. Occlusal plane angle. Relative to everything else, looks a little bit flat, but what does it look like kind of like skeletally overall? Okay, now look at this view. I mean, if you were like a plastic surgeon or something, I mean, what do you think about the face? Like, what does it look like? What could be different? I mean, like, what's less ideal? What about the cheekbones? What does it look like? What's that? Yeah, where are they, right? A little bit deficient, not so prominent, right? So a little bit of maybe mid-face deficiency. Now, what can we guess about our maxilla based off what we're seeing here and why? Like, what's the position AP of our maxilla and why? What? A little bit retrusive, retrognathic. And why do you say that? Okay, so the nasolabial angle is obtuse. So that's owing, of course, partially to the upturned nose, but also partially to the maxilla. What about the upper lip compared to the lower lip? You kind of see the lower lip a little bit more forward. All right, so there's a few things that are pointing to a little bit of a mid-face deficiency here. Let's look at the arch itself. High vaulted palate. Now, overall, is there a huge crowding concern? So I was taught in residency not to do anything on cases like, well, minus the crossbite part, right? Yeah, we got to fix that. But I mean, as far as like the arches go, it was always like, hey, just do it later, right? Because teeth will come in fine. So we might have addressed the crossbite with, you know, whatever, maybe some cross elastics, maybe some braces, maybe a quad helix, maybe something to get the teeth right. But the skeletal concern, at least in my program, wouldn't have been the number one concern here. But when I look at this case now, that's 100% my number one concern, right? You get the skeleton right, it's harder to get it right later. The older you are, the less skeletal changes you have, and the more anchorage requirements you have, which means the more invasive you have to be in order to get skeletal changes. So I'm going to get as much as we can at this age. How about our lower? Anything stand out here that you are worried about? I'll be impressed if you pick it up, but I think you will. Okay, we have lingual tipping, yes. Makes sense with the smaller maxilla. I mean, I haven't showed you have I showed you a center occlusal yet? Or a center photo, intraoral? Okay, just you're seeing kind of the stretch there? Yeah, so she may be a little bit tongue-tied. Honestly, I'd have to go back and look. But we talked about the midline being off, right? So let's have a vote. I don't think I've showed you a center intraoral, right? Yet? Okay. So is there a unilateral crossbite or is there not a unilateral crossbite? You think there is? Okay, we've got one vote for yes. Okay, a couple votes for yes. What's saying that there might be? So the left side of the screen. So her right side is more tipped inward than her left side. Okay, so what does that tell you? Who agrees that because the midline looks good in this photo, it's likely not a skeletal discrepancy? What is a skeletal discrepancy? What is asymmetric growth of the mandible? Huh? Yeah. So when you have asymmetric growth of the mandible, you typically have a condyle or mandibular body or both that's bigger on one side than the other. Okay? How does that affect what you see in this photo? Not really much as far as the teeth relate to the jaw. Does that make sense? Meaning the jaw is growing to one side, but the teeth within the jaw are just moving along with whatever's happening at the condyle and the ramus, right? So if you're looking just at this photo here, whether it was asymmetric growth or whether it was a shift in the mandible, doesn't matter. I mean, it's going to look the same from here, right? We don't really know. Yes? We'll look at it. But if she did, what would that tell you? Or what? Okay, it could tell you deep bite. Yes, I always want you to connect lower anterior wear with deep bite. That's the most common cause of it. But in a case where there might be some maxillary deficiency, could also tell you that you might want to keep an eye out for more of an anterior crossbite, right? Or an anterior edge-to-edge relationship, okay? What's one more thing? Let's put, what is one more thing? Look at the teeth. Look at the teeth. One more thing about the teeth that you may want to keep an eye on. And you can't really see it as good from this picture as you probably will be able to from other pictures. The left primary first molar? Yeah, what's going on with that? Very good. Do you guys see that? Yeah, so that left primary first molar a little bit lower, so we want to keep an eye out for what? Ankylosis, right? And if we have ankylosis, what do we want to do? Extract it. When? Right away. Why? Okay, ridge defect. Why else? Thinking more orthodontically. Okay, thinking more orthodontically. I think I heard it. Say what? Right. Yeah. So you have extrusion of the opposing arch or vertical deficiency of the arch that's trying to come up and kind of held back by this tooth. You end up with maxillary cants, right? Again, we can fix that later, but it's kind of a big pain in the butt. Much easier to prevent than it is to correct. Okay? So here's our left side occlusion. You can see that we're not in a crossbite, although we do have a tendency on that right side. And then we were right. Okay? So not a full lingual crossbite. I think if it was a full lingual crossbite, you would have seen that left side even more upright than you do, but definitely more of a crossbite on the left side all the way up to the level of the canine. Now, hopefully we have a shift, right? Because if we have a shift, then we expand. Where does the midline go? Yeah, back to the middle. Okay? Does she have lower incisor wear? Not so much. A little bit, maybe on that upper right central. Is it due to a deep bite? Yeah, not in this case, right? Maybe some anterior wear. Those are the edges there. You can see them a little bit better. And at this point, you can definitely see the first and second primary molars quite submerged. Okay, here's our pano. Again, if we did nothing, would these teeth likely come in? I would guess yes. Better than not. Like if I had to bet my entire life savings on this case and I had to pick all the teeth will come in or one of the teeth will become completely impacted and not come in, I would guess they would all come in. Okay? There's no huge red flags. The tips of the canines are past the apices of the laterals. They're not crossing over the root at all on the upper or the lower. The eruption pattern is relatively normal. The first premolar is in front of the second premolar, in front of the canine. Like everything's kind of happening the way that it normally would. The 12-year molars, I mean, they're not at high risk for impaction. So probably if we did nothing, all of the teeth would come in. What do we see skeletally as it relates to the maxilla? Yeah, deficient in which dimensions? So anterior, posterior. So it is retrusive, right? You can see that. If you look at SNA so SNA is going to be reduced or increased. S and A is going to be reduced. A and B is going to be reduced or increased. Reduced, right? Possibly even negative. We'd have to trace it out, right? So upper jaw compared to the lower jaw, upper jaw is set back, lower jaw is a little bit more forward. And it seems as though, to me, the lower jaw looks pretty normal compared to the rest of everything else, and the upper jaw is retrusive. That's what it looks like to me. That's my take on this case, okay? Airway. Again, it's a screening, 60-something, a little bit shy at the area of the tonsils beneath the tongue there. Again, you'll ask the questions. TMJ looks normal. Okay, so how are we going to treat this case? All right, we're going to expand. We can design the expander. What kind of expander do you want to use? What's that? Bonded RPE? What teeth are you going to cover? All right, you could do all the way 6s to Cs. That would give you even more anchorage on the Cs there. Or you could do 6s to Ds, usually pretty sufficient in a patient this age. Okay, so we expand. That corrects our crossbite. You see the midline's not terribly off, which is good. The shift is small. All right, so what else are we going to do? Anything? Just expand. Okay, reversible headgear. And what is that going to do? Yep, some skeletal, some dental. What force are you going to use for your face mask? How many hours a day are you going to ask to wear them? Are you going to do anything different with your expansion as you do that? What do you normally use? Yeah, I mean, it's fine, right? You learn the animals, you learn the products that you use, and you use that. But like at some point, you want to look into what you're using as well, right? Is it an 8-ounce elastic? Is it 12 ounce? And they do grams and ounces. I typically in my office I talk ounces just because I don't know, we're in America and that's what they do. But all the literature usually points to grams, so you have to do the conversion. But yeah, typically somewhere between 8 and 12 ounces per side. You're going to see maxillary protraction. You want to have them wear that at least every night. The more hours they get with it, the more response that you would expect to see. And you're going to have a trade-off between skeletal protraction and maxillary protraction of the dentition itself. Although with good rooted primary teeth, the maxillary protraction of the dentition is typically pretty small. So bonded RPE, face mask, reversible headgear, this is what that looks like. This is actually my niece, so she was treated remotely, so we got lots of fun selfies to make sure things were on track. You can see the amount of expansion that we achieved with this case. We pretty much maxed out the expander. We got as much as we could with the expansion screw that we had. And you can see she wore that reverse pull face mask. She wore it well. I mean, granted, she's got the expander in there, so you're seeing an artificial opening of the bite, and as the bite opens, the mandible drops down and back, and so that overjet's going to seem relatively increased. But something to remember, I've never turned a class 3 case into a class 2 case forever. We'll put it that way, okay? Ever. Never done that, right? So I don't worry at all about how much overjet I have on a class 3 case, ever at this age, okay? I get as much as I possibly can. Pretty much we'll wear the face mask until we're not seeing changes, all right? So over the course of 4 to 6 weeks, we'll see them back. If we're not seeing any more changes and we're not continuing to make progress, one of two things has happened. Either A, they're burnt out, or B, we've kind of hit our max as far as what they're going to move with this set of treatment, and so we'll kind of stop from there. You can see as we expand, those teeth are going to come down a little bit. You can see already some changes in the facial structure. She had this on for 7 months total. Here's the before and after facial changes. Now, how does that lower? Do you think that the midline went back on based on these photos? Maybe a little bit. Not as much? All right. Smiling before and after. So, and the magnification of the pictures probably doesn't help this, but what dimension do you feel like changed the most? What's that? The AP? Definitely got some projection of the maxilla for sure, right? But also, just note the vertical changes as well, right? I mean, now granted, there's 7 months of growth, but 7 months of growth is not a lot. But you see like quite a significant vertical increase as well. Now, is that the vertical increase? I want you to think about this. Is that the vertical increase that we're probably going to see long term? Like, or another way to ask that, what accounts for that vertical increase? Why do we have that increase in assuming that her teeth are touching in both of these photos and there's not an expander in both of these photos, both of those things are true. So what accounts for the change in the vertical specifically? No ideas? What's that? So the mandible will follow the maxilla, but what accounts for the maxillary change, or what accounts for the increase in vertical? Okay, the expander. Mechanically, the jaw comes down. That's part of it, right? So definitely part of it is the jaw itself moving inferiorly as it expands. But what's another part of the vertical that you're going to see now that you might not see later? Okay, yeah, normal growth is downward forward, but again, 7 months. What changes about the teeth when you expand, typically? Yeah, you get buccal tipping, right? So you're in a situation where typically the upper teeth are tipped a little bit outward. You're going to do your best to upright the lower teeth, but typically they're propped open a little bit with the teeth themselves, right? So as those teeth settle, that vertical is going to settle as well. This is the day that the expander came off. Right? There's the change in the arch shape. And then a few days later, once the tissues heal up. Here's our lower. Lost the canine at that point. Again, we're waiting for the tongue to move things out. I don't remember if we ran cross elastics on this case or not. I'd have to go look it up. There's that artificial opening of the bite. You can see we're edge to edge on both sides, almost in a buccal crossbite, but not quite. My guess is we did not run those elastics. And the midline is still a little bit off to the left, which means that there was asymmetric growth, right? Not ideal, but caught it relatively early, but still not ideal. And there's the before and after there. Here's our after pano. Again, compared to before, you're going to see those centrals tip forward using that space. And again, propped open in our final ceph as well. Very steep case, got steeper with treatment. Maxilla comes down and forward. Jaws artificially open. That makes sense. Airway changes, I mean, don't write home about it, right? Probably the majority of this is head posture. And our TMJ films. So, but this is the actual changes in the jaws themselves. And this is what we never used to be able to quantify in the way that we can now. So when we superimpose on the anterior cranial base, you can actually see the difference that you made with your treatment and how effective it was. And we could measure this out, I mean, right around 3 millimeters or so at A point. This is skeletal change that you would have a very, very difficult time obtaining later, certainly without TADs or some sort of skeletal anchorage that you can achieve when the child is young. You can see from a width standpoint all the way up to the level of the cheeks, dentition, and that is it. So until next time, any other questions?